So Brian Wheeler's been an invaluable member of our team and really complementary to many disciplines. Is going to be talking about intraoperative monitoring, which he is our supervisor here at UW Health. Been a delight working with you, and high time we learned what you're actually doing. So we'll let you do Grant now.
Good morning, everyone. Thank you for having me today to present. So as Dr. Dempsey said, my name is Brian Wheeler. I'm supervisor of intraoperative neuromonitoring. I've been in the field doing this for about 24 years. I've been here at UW Health for almost 11. The standard slide, I have no companies to disclose and no relevant financial issues. So what is IONM? Stands for Intraoperative Neuromonitoring. So we monitor the central and peripheral nervous system during procedures that put those structures at risk. It can be various services, including neurosurgery, orthopedic spine, vascular, interventional radiology, even plastics at times. We take care of both the adult and pediatric populations here. There's quite a few modalities testing that we do during certain cases. As you can see the list there, we have motor evoked potentials, somatosensory evoked potentials, EMG, both triggered and spontaneous, brainstem auditory evoked potentials, EEG, nerve action potentials, cortical, motor, speech, and sensory mapping, subcortical mapping, dorsal column mapping, and D-wave as well, which is part of spinal procedures. So first we'll talk about motor evoked potentials. We use this to monitor the motor pathways of the brain and spinal cord. There's two ways of delivering stimulation, both transcranially through the skull and then direct cortical stimulation, where we have a electrode or a 1x4 strip electrode directly on the motor cortex to deliver the stimulation. For transcranial, we use corkscrews. You may see us sort of screwing these electrodes into the patient's scalp. And the reason we use those is that the corkscrew is a little bit longer needle than our straight subdermal needle. So the more contact we have with the skin, more surface area, the better stimulation we provide. Transcranial MEPs are really best for spinal procedures. They can be used for craniotomies. They're not quite as sensitive, and I'll get into that a little bit. The direct cortical stimulated MEPs really are best for craniotomies, but not always able to be used depending on the area of exposure and whether or not we're close enough to the motor cortex to be able to insert a 1x4 strip electrode in place. So again, we can use a 1x4, 1x6, a 1x8 strip electrode to provide that stimulation. And then we record the responses from various muscles in the arms and legs, that we place subdermal needle electrodes to provide that response recording. And the muscle groups monitored are based on the type of surgery. So when we're doing a cervical spine procedure, we focus mainly on the upper extremities. We'll have more muscles monitored in the upper extremities and maybe only 2 in the legs. Whereas if we're performing a procedure below T1, we focus more on the lower extremity responses. So we'll have maybe 3 muscles in each leg, and then we'll use muscles in the hand as just a control. And what I mean by that is if we start to see changes in our lower extremity motor evoked potentials, we can use the upper extremity, the hand responses, to determine whether or not it's anesthetic related. Is it actually related to what's happening during the procedure, or if we're having a technical issue? So here's one screenshot of motor evoked potentials during a spine case. As you can see, the top 2 traces are the left and right APB muscles or thenar muscles in the hand. And then we also have the vastus lateralis, the tibialis anterior, and the adductor hallucis in the foot. So we have 3 lower extremity muscles. And that would be a common setup for our cases that are below T1. These are two different screenshots of motor evoked potentials in craniotomies. The screenshot on the left is direct cortical stimulated motor evoked potentials. So that is through probably a 1x4 strip placed on the motor cortex, and we're stimulating in this example at 13 milliamps to elicit those motor evoked potentials in the upper extremity. It's very difficult to get both upper and lower extremity with the direct cortical stimulation, because we can only stimulate through one contact. And so it's a smaller surface area that we're stimulating. Once in a great while, we're able to get lower extremity as well. That usually needs higher stimulation level, which can cause movement of the patient. And obviously under the microscope, it looks like an earthquake when we do that. So we have to balance our stimulation intensity to be able to get reliable responses and not disrupt the surgery. The screenshot on the right is transcranial evoked potentials during craniotomy. And you'll notice that on the left side of that screenshot, we have more muscles than on the right. We do this for supratentorial tumors that are lateralized to one hemisphere. So we focus more on the operative side of the brain and operative side of the body. So this would be a right craniotomy where we're focusing on the left body. Now, you'll see the bottom two channels on each side of that screenshot are the opposite or ipsilateral side of surgery. We monitor something called crossover. And when you'll hear us in the OR say we have good motor evoked potentials and no crossover. What that means is that we don't believe, anyways, from our recordings, that we are stimulating subcortical pathways in the brain that are eliciting those responses. So what can happen is if we stimulate too high, we can actually stimulate below the level of the tumor and trigger subcortical pathways to where the surgeon can be resecting, and we have stable motors throughout the case, and suddenly the patient wakes up hemiplegic. We've had 2 cases like that in the past, which is why we started monitoring this crossover phenomenon, which actually didn't really come into our field until maybe 5-6 years ago, where people started noticing that there's this possibility of stimulating below the level of the tumor. So when we have crossover and we actually get responses on the same side that we're doing the surgery on, so right craniotomy, and we're getting responses on the right hand and right foot when we're stimulating for left body, we have to say that the motor evoked potentials are unreliable. We can't tell you if you're harming subcortical pathways or even the motor cortex itself. So that's where the direct cortical stimulation really comes into play and is much more accurate than the transcranial stimulation. The other issue we also have to be aware of, which we'll get into here shortly, is cortical sag with larger tumor resections. So our warning criteria for motor evoked potentials for spine cases is really a present and absent warning criteria. We do, however, take in consideration our thresholds increasing and amplitude drop. So you can see if we have an increase in stimulation threshold by 100 volts or more due to a significant drop in amplitude over 60% from baseline, we will warn the surgeon that we're seeing changes. Now, again, that's more for spine than it is for craniotomies. Craniotomies, we're looking for a drop in amplitude over 50% in the entire hemibody or an entire limb without improvement with increased stimulation. So if we're doing transcranial motors and we are seeing a drop in amplitude and we're increasing threshold and we're just not getting the amplitude back, that would be a warning to the surgeon. However, we do have to take into consideration cortical sag or shift with larger tumor resections. And we've seen this, I think a lot of people in this room have seen this when we stimulate at our baseline and we go quite a bit, we increase our stimulation by quite a bit, we get our responses back, but we're stimulating at a much higher level. And that's because the motor cortex is actually sagging away from the skull due to the tumor being resected and things sort of shifting and sagging away. So this is something that we have to discuss with the surgeon and sort of get their input as to, do you think there's cortical sag or shift? Do you think this is really due to resection and irritating the subcortical pathways or irritating the motor cortex. And we'll hash that out right there in a moment and then continue from there. We also watch for trends. If we see an entire limb losing amplitude with every stimulation, and this is more for the direct cortical stimulation, we may warn the surgeon prior to that loss, that sort of warning criteria of 50%, because we're seeing a trend. And we want to make the surgeon aware that we don't feel that it's anything technical, and we think there could be some irritation of pathways, and the surgeon can then sort of make that determination based on anatomy and where they feel they are, if they need to continue resecting or stop resecting in that area.
Brian, do you keep track, or is there any general relevance to the stimulation required, or is that all specific to the patient in front of you and it changes from their original baseline? In other words, in some other monitoring, you will say, I'm this close to because of the amount of stimulation I need or signal I receive. Or is that very specific to the patient you're working on?
That, I believe what you're speaking of is more subcortical or subcortical mapping, and that is sort of a standard method and from patient to patient. Next up, somatosensory evoked potentials. We use these to monitor sensory tracts of the brain and spinal cord. So what we're doing is stimulating peripheral nerves and recording from peripheral points in the limbs, also from the brainstem and from the sensory cortex. And the nerves that we tend to use the most are really median and tibial, but we'll use median or ulnar for upper extremity and posterior tibial nerve or the perineal nerve for lower extremity. These responses are averaged. It's about 200 averages, so we stimulate 200 times, and every stimulation there's a response that's recorded. And those get averaged together to give us a nice clean waveform to let us really see that response. So the nerves that we use too are also based on the level of surgery. If we're doing a high cervical C1 to C2 fusion, I tend to use the median nerve, that comes in at C5, C6. It's a larger nerve, tends to give us a bigger response in most patients. Obviously, if we're in the lower cervical, we're doing, C6 to T1 fusion, we'll use the ulnar nerve as that comes in at that level, the C7, C8 nerve root. And tibioperineal, the tibial is just the easier, lower response to get. Perineal, we don't do that often unless we feel there's a need. So to record the responses, we place the needles on the head, also at peripheral points, Erb's point on each side of the neck, the popliteal fossa at the back of the knee. Those peripheral points help with watching for positioning changes. If patient's prone with sort of arms up in the Superman position, we can have ulnar nerve compression and see a loss of amplitude in our upper SSEP signals, which clues us in that there's possibly a positional issue, and we'll remedy that by working with anesthesia to reposition the arm. SSEPs can also be recorded from a cortical strip on the brain as well. Just like we stimulate with motors, we can record an SSEP from the strip electrode as well. TIVA, as for motor evoked potentials, we prefer a total TIVA, no gas at all. But for SSEPs, gas can be used up to a half MAC if MEPs are not part of the monitoring paradigm. If we do carotids with EEG and SSEPs, we can sort of do a dirty TIVA and with gas and propofol and be able to get a nice clean EEG, continuous EEG, and good SSEPs. So here's a screenshot of SSEPs. Top two windows are the upper extremity. In those windows, the top two channels are cortical responses. The third channel down is subcortical response from the brainstem, and the bottom channel is our peripheral response from Erb's point. Same with the lower two windows. The first two are cortical. The subcortical responses in lower extremity SSEPs are very difficult to get. They're not always present, but we do have the peripheral point at the popliteal fossa to watch for any positioning issues. Warning criteria: amplitude decrease of 50% from baseline, latency increase 10% from baseline. Usually our initial baselines are higher amplitude than they are after exposure. We tend to reset baselines after exposure once the patient is in sort of a steady state of anesthesia, and also temperature. We may start out with shifted responses with longer latency because the patient is sort of cool. And as the patient warms, we see those latencies shorten. So we'll also reset our baseline. So we're following the most current data from the patient. And we always reset the baseline before any type of correction or resection is performed. We don't want to reset them while the major sort of the key points of the surgery are taking place. We don't want to try to skew our data and say, well, we're going to reset now and it looks okay. And we keep losing amplitude and thinking, well, we're just going to reset because it's we think it's temperature, we think it's this, we just leave it alone at that point. So we always reset before major points in the procedure. And for SSEPs, the warning criteria is no different between spine and craniotomy. Brainstem auditory evoked potentials monitors the eighth nerve. We perform those by placing foam inserts in the ear that deliver clicks and different sounds that stimulate the eighth nerve, and we record those responses again with needles on the head. And again, that's an average response, 500 to 1,000 averages. The stimulation is switched from side to side. So we have clicks in one ear going that we're actually monitoring and a white noise in the other. And then when it switches to the other side to monitor the other side of the eighth nerve. 5 waveforms that we record, as you can see, are generated by those structures, and waves 1, 3, and 5 are what we're most concerned about during surgery. Those are the most prevalent waveforms in the OR. So we'll see, we watch those for amplitude and latency increases. And bears are not affected by anesthesia. They can use anything they want. We won't see a change. What we do see a change, or when we do see a change, it's temperature related or stretch related, or related to resecting a tumor off of the eighth nerve, where it's just irritating that nerve. And it doesn't take a whole lot to decrease our brainstem potentials with irritation of that nerve. It's a very sort of cranky nerve, I like to say. You can almost just breathe on it and it doesn't like that, and it won't produce those responses. So here's a screenshot of nice baseline bilateral evoked potentials. You can see the waveforms are marked Roman numeral 1, 3, and 5 with amplitude markers. The top 2 traces are the side that we're stimulating and watching. The bottom is the contralateral side during that stimulation. And that just helps us identify waveform 5 a little bit better and where that wave comes in. And here's a screenshot and warning criteria. Again, an increase in peak latency of 0.6 milliseconds or more of any wave, or an increase of inner peak latency by 0.6 milliseconds or more, waves 1 to 3, 3 to 5, and even 1 to 5. And then a decrease in amplitude of 50%, or sudden and complete loss of waves 3 or 5. And you can see on the right side of this screenshot, we had a complete loss of a brainstem auditory evoked potential. I'm not sure what procedure it was, if it was a tumor or MVD, but that's what that would look like. A little bit tough to see with the dark purple trace there, but EMG, we have spontaneous and triggered EMG, which consists of continuous recording from muscles, either cranial nerves, spinal nerve roots, peripheral nerves. If the nerve is irritated, it'll begin to fire or twitch, and we pick up that firing and twitching with the needles that we place. Triggered EMG consists of stimulation of cranial nerve, spinal nerve root, or peripheral nerve and recording a response from a muscle. Anesthesia cannot use muscle relaxants after induction or intubation. And our warning criteria is irritation or firing that lasts more than 5 to 10 seconds. Depending on the type of case, we may inform immediately, especially when it comes to cranial nerves. We see a quick firing starting that's lasting a couple seconds. We will usually notify the surgeon of that. A lot of times with spinal surgery, we get EMG firing and that's because the surgeon is working or manipulating nerve roots, and we sort of know that that's happening. It's not, we may inform, but we're not worried. What we would be worried about is when they stop working at that level and it continues to fire. That's when we would be a little bit more concerned. Nerve action potential. These are used for brachial plexus or peripheral nerve surgery. Helps identify any continuity of transmission of an injured nerve. Surgeons make the decision based on the presence or absence of that NAP. If it's present, the surgeon will leave the nerve alone, may not perform the grafting, maybe just perform a neurolysis. If it is absent, the surgeon will perform a transfer or grafting. We use handheld probes, double and triple hook probes, which are directly placed on the nerve. One is stimulation, one is recording, and we try to pick up that transmission through the injured section of that nerve. Again, not affected by anesthetics or muscle relaxant, but TIVA may need to be used depending on other modalities that are also being used during the procedure, like motor evoked potentials or neurogenic evoked potentials. Neurogenic motor evoked potentials are direct stimulation of a cervical spinal root and recording from the brachial plexus or recording in a peripheral nerve in the arm and seeing if the nerve root is evolved or still functional. Those are, again, used with the double and triple hook probes and can be difficult to record. Surgeon has to have very still controlled hands, and the field needs to be dry as possible, so we don't have any spread or responses or spread of the stimulation. But those are some of the trickier responses to actually record. EEG, obviously, we're recording cortical brain activity, usually used in vascular procedures, TCARs, carotid endarterectomies, aortic aneurysm repairs, neuroendovascular, aneurysm embolizations or aneurysm clippings. Can be used to help determine depth of anesthesia as well. We will monitor EEG during spinal procedures and craniotomies to help anesthesia determine if the patient is getting light or is too deep. We also use it to monitor after discharges or electrographic seizures during motor and speech mapping, and that is done by, again, a 1x4 strip placed directly on the cortex of the brain, close to the stimulation as possible. And then the leads can either be surface leads that we glue on or subdermal needle electrodes, depending on the type of procedure we're doing and what's needed. The screenshot of what EEG during a carotid endarterectomy. Dorsal column mapping. This is used for intramedullary spinal cord tumors. Try to find the midline of the spinal cord to incise, to approach the tumor. Stimulate the spinal cord and record from the brain with the same electrodes we place for somatosensory evoked potentials, because that is what this is basically a somatosensory evoked potential that is elicited from stimulation of the spinal cord. Spinal cord below, stimulation of the cord below the spinal level of upper extremities will result only in a presence or absence. Our recording electrode for lower extremity is at the vertex. Obviously, the lower extremity somatosensory cortex dives down in between and the falx and deep in the midline of the brain. So we can't really tell what's left or right. We can just say it's there or not there. But if you're stimulating in the upper extremity part of the spinal cord, we can tell you if it's coming from left brain, right brain, and you can move the probe from lateral to medial to try to find that physiological midline. Cortical motor speech and sensory mapping, obviously used during tumor resection, seizure focus resections during near eloquent areas. Motor mapping can be done awake or under general anesthesia. Consists of direct cortical stimulation and eliciting muscle responses that we record with our subdermal needles, or we find a dysfunction in speech where we're having the patient say months of the year or days or answering questions and trying to disrupt their speech when we stimulate. The techniques used for motor and speech mapping are different. They used to be one and the same. There's a newer technique that has come out over the last 10 years, a fast single train of stimulation for motor mapping that is used that elicits fewer seizures than the Penfield technique, which is the 2 to 3 second train at 60 hertz. So this is much safer for motor mapping, but speech mapping still uses the Penfield technique where you're stimulating for 2 to 3 seconds, which has a seizure incidence of up to 24%, where the fast train technique is 1 to 3%. Sensory mapping is used to locate the central sulcus, which can help identify the motor cortex and sensory cortex a little easier, can help decrease your time in motor mapping because you know where the central sulcus is located and you know where the motor cortex should be, where it's identified. And then we can also do continuous motor monitoring after the mapping, again with the 1x4 strip, directly stimulating the cortex and stimulating once every 2 seconds during the tumor resection. Subcortical motor mapping, this is for deeper resection of the tumor that were in close proximity to the white matter tracts. So we do direct monopolar cathodal stimulation to elicit muscle responses. And it is a near 1-to-1 ratio of milliamps to millimeters. So a response elicited at an intensity of 13 milliamps indicates approximately 13 millimeters away from the white matter tracts. The lower the threshold, the more accurate it becomes. If you're getting a response at 17 milliamps, could be 17 millimeters, could be 20 millimeters. But if you're getting a response at 5 milliamps, you're pretty much 5 millimeters away. And that's sort of our cutoff. When we get close to 5 milliamps and we're getting responses, that would sort of indicate to stop resecting in that area. We've seen as low as 1 to 2 milliamps, and where patients have not woken up with a deficit, which is great, but that is a little bit nerve-wracking in the OR. And patients may have transient or permanent weakness with thresholds below 3 milliamps. That's it.
Always felt that track mapping is could be used on most of these if you have enough power or some sort of consistency.
And we really don't know if tumor consistency affects,
of course,
threshold, which is something I've been thinking about looking into, but takes some time and a lot of cases to sort of make that determination.
The other thing you might want to look at is the amount of edema on the T2 on the MRI scan. See how that affects conduction.
Yeah, correct.
Cool. Questions?
Brian, for neuromonitoring, do you guys treat endovascular cases similar to brain?
We do. We tend to be a little bit more cautious, like with motor evoked potentials, maybe a little bit earlier of a warning because they are transcranial, but they should be pretty consistent because you're not resecting anything, so there shouldn't be issues of sag or shift of the brain. So especially with spinal angios and embos, we really pay close attention to more amplitude and threshold than we do presence or absence.
I asked you this before. Is the trigger EMG the same thing as CMAP?
It's the CMAP is what we're recording, compound muscle action potential. But yes, it's very similar. So you could say we have CMAPs with motor evoked potentials, and we have CMAPs with triggered EMG. So it's the result that we're getting, the response, that's the CMAP, the actual muscle potential. Yes.
Do you do any tracing of event-related potentials, and how do you distinguish those?
I'm sorry, I can't hear.
Do you do any tracing of event-related potentials, and then how do you distinguish those from evoked potentials?
I just have a hard time.
How do you record event-related potentials, and then how do you distinguish those from evoked potentials?
So I'm not sure I know what you mean by event.
Like resulting from cortical activity rather than from a stimulus.
Yeah, that is a good question. So we see the stimulation artifact when we stimulate, and that is set at a certain duration and frequency. So we know where that should come in, and we can sort of break out the response from that stimulation artifact. There are times, especially with nerve action potentials, where the stimulation is so close to the recording electrode that it's hard to see the actual potential because of the stimulation. But we were able to sort of tease that out depending on various factors.
I'd follow up on that by answering, what about you provoking a seizure? How do you monitor it? How do you treat it?
So evoking a seizure, which during direct cortical stimulation, we monitor that. We can monitor that via the strip that's on the brain already. We can plug the other contacts in and record EEG while we're stimulating through one. And we, treatment for that, when we do direct cortical stimulation, especially the mapping portion, we have the neurologists in the room. They would help make the decision on medications to give dosage. But we also have cold irrigation that can be put on the brain to help stop that activity. There's also what they call an ictal disrupt, that we can send a pulse through to disrupt that seizure and try to make it stop if the cold irrigation doesn't work. And then the next step obviously would be pharmaceutical intervention. Yes.
This was a great talk, Brian. Would it be possible for us to get the slides as a residency before? I think this would have been, and will continue to be super helpful in resident education.
Yes.
More and more residents.
Yeah, for sure. Definitely. Thank you.
Thank you very much.
Thank you.
Appreciate it very much.
Thank you.